Very good morning to dear Professor. My name is Muhammad Azmi Hamron, and we are from Group 2 with my colleagues Hariri, Tan Jun Kang, and Shamima. Will be presenting patient waiting time in Hospital Semporna Outpatient Clinic. This is just a glimpse of institution background, established in 1970. Okay, and then it is a district hospital with type 4 non-specialty hospital. We have 267 staffs with 30 medical officers and 76 nurses. Right. And Hospital Semporna is one of the cluster hospital that consists of 4 hospitals in the one cluster, and our hospital lead is Hospital Tawau. And as you can see, Hospital Semporna situated at the east coast of Sabah, Malaysia. This is our vision, mission, and objectives. Okay, our mission is to provide excellent health services towards a healthy and prosperous society. And by our mission is to gather the teamwork, the practice corporate culture, self-facilities, community involvement. And the objectives provide friendly, efficient, fair, effective medical services, as well as improving the level of quality so that customers can enjoy lasting health. And this is our hospital service, which consists of clinical and ancillary department. As you can see over here, the most important is we have inpatient service and we have 24 hours emergency and trauma services. And this is just a organization chart, okay, for the specialist hospital or outpatient clinic. Sorry, outpatient clinic. All right, so just a brief of external mapping. We have a stable economy. We have a very good political background and support from our government. And we have advanced technology in several parts of this Sabah. But Semporna is quite at the middle, that we have advanced technology from private institution itself. And then the competitiveness, of course, Hospital Semporna is the only one government hospital situated in Semporna, and most of others is private hospital and also general practice. And for the internal mapping, we have value creating strength and value reducing weakness, but we want to focus our strength that we have in-house with the specialists and multi-skilled strength medical officers, which having a clear directional mission and vision. And so, without further ado, we introduce the outpatient clinic. Okay, the outpatient clinic is one of the mostly busiest hospital in clinic in Hospital Semporna. And we have you see, based on the graph 2022 until 2024, okay, we have increasing amount of cases, especially for the follow-up cases. And you can see the stable increment, okay, from 2022 and 2023 for the new cases. However, a bit drop in 2024. However, if you can see on the follow-up, it is increasing. Right, so we have several issues, but the most important issue is increasing complaints on waiting time during clinic days, because the optimum one is estimated is 120 minutes. But the average, based on the calculation and collection of data, we achieve 180 minutes per consultation time. Okay, so what is the contributing factors? We have short clinic time, and visiting comes late and depart early, and only one specialist attending for the increasing amount of patient. Low discharge by high new cases, very deficient facilities. We have limited waiting area and toilet and quality system. And we have deficient supporting staffs, especially doctor-patient ratio, which is estimated 1/40 patients. And last problem statement, increasing complaints on waiting time during clinic days in Hospital Semporna. This is the issue that we want to tackle. So I pass to my friends.
Thank you, Dr. Azmi. Dr. Shamima, I'll be presenting from here onwards. Let's move on to problem tree analysis. So our issue is this. The central problem is longer patient consultation waiting time. So let's look at the root causes, which is, we have 3 here. The first is the lack of financial support. So Due to that lack of financial support, it leads to deficient facilities like what Azmi has mentioned above, and that leads to operational inefficiency as well. And moving on to the second factor, which is no resident specialists available. We still rely on tertiary centers to send one visiting specialist to our outpatient department. And they do come late and depart early, which results in short clinic time, which is only 9 a.m. to 1 p.m. Moving on to the third cause, which is high turnover and resignation of staffs. As I said, we only have one visiting specialist and we run our clinics with other medical officers. And our doctor to patient ratio is 1 to 40. This leads to limited human resources. All these issues leads to longer patient consultation waiting time, which ultimately has impact on poor outcome of patient, reduced patient satisfaction, reduced staff satisfaction itself because staffs are being fatigued and exhausted. So this ultimately leads to increased burden on our healthcare, increased morbidity and mortality, and also gives bad image on our government hospitals. So next slide. Okay, so these are our operational definitions. Waiting time is defined as time measured from time of registration till the time being called for a doctor's consultation. As for the visiting team, it's defined as a visiting specialist team, usually with accompanying doctors from the tertiary specialist hospital. So next slide. As the saying goes, you cannot measure something that you cannot improve something that you can't measure. So here we are with our indicators. The first being the average waiting time. It's defined as the actual average time spent by each patient waiting for consultations. And how do we measure it? By taking the total individual patients waiting time, divide over the total number of patients in clinic. Our target is to reach less than 120 minutes. Okay, second. Okay, as for the second is the waiting time achievement. It's defined as the percentage of patient achieving the recommended waiting time for consultation, which is our target is more than 80%. How do we calculate this? Is by taking the total patient with less than 120 minutes of waiting time, divide by total number of patients in clinic on that day. Okay, the third indicator would be our doctor to patient ratio. As we mentioned, our current doctor to patient ratio is 1 to 40 and our target is 1 to 20. So how do we calculate that? We take the number of attending doctors in clinic and divide by total number of patients per clinic days. Moving on to the fourth one, which is our clinic operation hours. The number of hours the clinic is open relative to the number of patients visits per day. So our target is 1 hour. We want to see 10 patients at least. So we calculate it by taking the total hours of clinic operating hours per day, divide by total number of patients visit per day. And the last one would be the percentage of waiting time complaints. The trend of increasing patient complaints about long waiting times, we aim to reduce it by at least 20%. So the formula would be total number of complaints on waiting time and divided to total number of patient complaints within the same year. And we intend to do this both pre and post our pilot project. So I will hand over to Dr. Hariri. Thank you.
Yeah, thank you, Dr. Shamima. I'm Dr. Hariri here. We'll continue with the presentations. So we are talking about the analysis. This is we are using quality management activities, which is structured around these three questions. First is measurement. How are we doing? Where we assess current performance metrics such as patient waiting times and also clinic efficiency. And then second one, assessment. Are we expecting the expectation? We compare our findings against the predefined target. For example, in this case, our waiting time is less than 120 minutes, and then we will identify the gaps, and then we proceed with the improvement. How can we improve the performance? So based on gaps, we will develop actionable strategies. For example, like trialing a resident specialist or extending the clinic hours. And okay, and then it's okay. Next. Okay, so now we are using the multi-criteria decision matrix, which is to prioritize our root cause problems. We have four main key area, which is the relevance, means the importance of the issue's impact and related to the stakeholder, which weighted about 0.3. And then second is feasible, means the availability of human, financial, material, and technical resources required to solve the issues with the weight of 0.2. And then about the timeliness, the urgency of required actions to manage the issue within a time frame identified with the weighted of 0.2. And also the last one about the applicability of the issue, the appropriateness of the issue to be managed in relation to the related stakeholder with weighted 0.3. According to these three root causes, our second issue, which is no resident specialist available, has the highest total, which is 2.8, and then we rank it as the main prioritized problem, and then followed by second one, high turnover staff resignation, and last one, lack financial support. Next. Okay, this is the opportunity for improvement. We are applying the PDSA framework, which is plan, do, study, and act. Next. Okay, but before we proceed with the PDSA, here is the Six Sigma of the quality healthcare, which is we have to find the ways. So here are the ways that we could identify. First is waiting, where the wasted time on awaiting for visiting specialists to arrive at 9 a.m. And then the second one is about the motion, where specialists and the team coming far from the another place to our clinics. And then about the non-utilized talent, the availability of the senior medical officers, which is just need minimal training from the specialist to run the clinics. And then the fourth one is about extra processing, which is patient being rescheduled due to unforeseen unavailability of specialists. And then the last one about the overburden, which is called in Japanese term muri, which is a single specialist, just single specialist handling the excessive caseload. Next. Okay, so we come out with our project trial, which is a 3-month resident specialist, which involve the stakeholder engagement, including hospital administrator, where they approve the budget and also the resources, and then the departments itself, where the HOD select the specialist and also define the job scope, and also about the clinic staff, they should acknowledge and train the new workflow, for example, like patient scheduling and also triage. And last one about the patient itself, where we should deliver a good information through bunting and also website. And then about the specialist criteria, he or she must be chosen by the HOD and also have to be willingness to commit 3 months trial posting. About the operational, we should consider to extend the clinic hours from 8 to 4 p.m. And then we could provide extra days clinic per week, can be 2 to 3 times per week. And then we should ask the specialist to train our resident medical officer to run the clinic and also to increase their credentialing and also privileging. Next. Okay, I pass to Dr. David. Thank you.
Okay, thank you, Dr. Hari. I'm Dr. David Tan. So I'll be talking more in two details about the PDSA cycle. So the first one will be the planning stage. So with our objective being to have at least one resident specialist per discipline by the end of this year. So the primary focus will be on oncology, ops and gynae, and then pediatrics and medical services. What our prediction would be, we'll be having shorter consultation time, and then we have the second reduced waiting time, and then the third one would be to be able to extend clinic hours time if necessary. So what are the plans to carry out? So we plan to do, we start to have a trial with a resident specialist model for the first 3 months. And then after that, we negotiate for long-term contracts with specialists to stabilize staffing. And also we standardize the specialist schedules using statistical demand forecasting. How we're doing that, we'll be doing through the cluster committee meeting and HOS quarterly, and then with the state health department and the MOH collaboration meeting biannually. And then we will be starting off with the pilot project with one department first for 3-monthly schedule, as mentioned just now, and then the one-on-one in-house specialist MO training with continuous regular assessment. So the plan for the data collection would include the number of specialists, the clinic census, and the patient waiting time data. Next would be the next slide, please. Next would be the due and the execution state. So how we're going to carry out the plan. So we will ask the first question will be the who part, which is the hospital management, the department head, and the identified resident specialist. What would be that assign the a selected specialist to the clinic for a trial period of 3 months, where would be the specialist outpatient clinic of Hospital Semporna. And then when would be the starting of December this year or earlier if possible. So we have to document the monthly clinic performance and the clinic census, including the patient volume, the operational hours, the doctor-patient ratio, and also the consultation time. We have to record the observations and the feedback from both patients and staff. Thirdly, would be the study stage. So the first step would be to analyze the collected data in quantitative form and also in a qualitative form. Qualitative would be interview and through the PSQ, focusing on the patient and the staffs. The second step would be compare the actual outcomes with the initial predictions using the table below. Thirdly, next slide, would be to identify the enabling factors and the possible hindering factors. So factors such as the patient factor, and then the staff factor, the team factor, management factor, and the technological factor. So with the focus of patient factor, might be the social factor, the complexity of the case, the compliance of the appointment time. Staff factor would be the attitude, the motivations, and the policy adherence. Team factor would be the communication and the teamwork and the supervision. Managerial factor would be the policy and goals and the stakeholders' involvement. Technology factor-wise would be the digital information system and having a systematic appointment scheduling and reminder. Next would be the acting stage. Next slide, please. I'll be talking what are the changes that need to be made. So we have to do the decision to revise, to implement, and extending the idea based on the evidence and the data provided. And then we should revise the policy regarding the duration of rotation and policy placement of the specialist. Also, we have to do the acceptability analysis and the continuous monitoring of the PDS AI cycle to be conducted regularly. So when is the next cycle? If the results are favorable based on the performance measurement, then the plan will be expanded to other disciplines and to the clinics or even the other cluster hospitals to include additional specialists in the future. So who will be important in Q here would be the QIP team, the quality team. So the role of the team leader would be the housed by the hospital director and the head of our OPD would be to lead the QIP process and then overseeing the whole process implementation, coordinating the meetings, and ensure the timeliness adherence. The project coordinator will be staffed by the senior MO. So he or she will be facilitating the data operations, gathering the feedback, and become the liaison officer between different departments. Administrative support will be held by the medical record officer or the hospital health information officer, which collects and analyzes the data, the patient data, the waiting time data, and the clinic performance metrics. And then here we have the nursing representative by the matron or the senior OPD staff nurse. Here they provide the insights of the daily clinic operations, the triage process, and the patient flow. IT support, not forgetting them from the hospital IT staff, would be to support data management and then the appointment system optimization and then the digital queue solutions and troubleshooting. So most important also would be the liaison officer, which is housed by the unit quality officer. The person will be in charge of gathering patient feedback and then managing the patient communication and satisfaction surveys, and also to monitor the quality practice compliances. That will be for my part. Moving on will be taken by Dr. Azmi. Thank you.
Thank you, David. Okay, as in conclusion, how we monitor and evaluate what we will do. Okay, we have 4 indicators that are patient waiting time, clinic operating hours, number of resident specialists appointed, and number of complaints related to waiting time. So we have our target, we have data source, we know how to collect the data, and the frequency itself, and who is responsible As a conclusion, patient waiting time, we have a target that is more than 80% achievement of less than 120 minutes waiting time, and we get from all the sensors. We do it monthly from digital or manual count from the admin officer itself. And as you can see, clinic operating hours also we get from digital or manual count, okay, from the clinic sensors itself. The number of residents, at least one per discipline for 3-monthly period, okay, from the HR records. And then we can do it quarterly by human resource unit and admin. And lastly, number of complaints. Our target is to get 20% reduction in waiting time and to related complaints based on the PSQ or the questionnaire itself. And then we can do it by quantitative trend analysis, okay, by annually from the quality unit itself. Okay, as a conclusion, okay, this issue, the persistent issue of excessive patient waiting time in hospitals Semporna outpatient clinic is significantly attributed to the absence of the resident specialist. So this is the problem, all right? But through the QIP itself, the stakeholders' involvement and a structured PDCA approach that was employed to try a resident specialist placement for 3 months with vigorous monitoring of outcomes, we can do this. Okay, this initiative will be monitored to ensure effectiveness, to ensure the alignment, okay, in providing goals, okay, to provide excellent care and improving service quality. By the end, quality is not an act but a habit. So this QIP lays the foundation for a culture of continuous improvement at Hospital Semporna. So I think that's all from us. This is our references, and thank you so much.